Dr. Partha, I would like to ask you first about your experience regarding muscle mass loss and sarcopenia with these drugs in your experience.
So I think it very much depends on, in our experience, also on the age of the patient when you're starting off.
Yes.
I think by nature, younger people will recover the muscle mass quicker. They are normally people who exercise a lot. We generally tend to see that 45, 50 upwards, you have to couple it with advice, as was mentioned
Yeah.
by our last speaker, resistance, etc.,
Strength training is
strength
very
training. I think it's
important.
very important to give that. I think what is happening right now, and this is what I was saying, doctors have a role, just like ma'am is doing, to be the guide. Because if you're going to do it unregulated, then you will really run the risk of people having, that sort of problem with sarcopenia and muscle mass. So it's very important to have the right advice when you're taking the drug. Weight loss is, and our bariatric surgery colleagues always says that, is that it's no good in just doing the surgery and let the patient go. You have to do a lot of work to continue that weight loss, so to speak.
And another important thing is that the guideline says you go from 2.5 milligram in 4 weeks to 5 milligram, then 7.5. No, do not do that. You understand your patient. If the patient is losing by 2.5 milligram, quite enough. There's no hurry to go to 5 milligram. And if you step up early to 5 milligram, suppose if a patient has lost 4 kgs right in the first month, what's the hurry? We can wait for another month. And if you hurry up in such type of patient, there you have chances of losing more the lean
Indian
mass
patients are
and
giving very
vessels.
good responses at low doses. Well, Dr. Reema, I'll have one question for you. We know we need high protein diet. How do you advise your vegetarian patients to manage that?
Oh, very tricky and very tough question. I play very safe games. I mean, if I am specialized in obesity, I would simply want my nutritional therapist to get into that without me half of my knowledge. However, at the same time, I would also like my nutritionist to be updated in such conferences about managing patients with GLP-1 analogs in terms of high calorie diets or likewise for exercise and all. What my nutritionist does it with this this vegetarian patients is he puts them on high protein supplements along with high protein diet like taking more sprouts, more grilled paneers, tofus, and yes, the specific supplements which are available in the market, which they know way better than what I know, should be there with a little more omega 3 fatty acids as well, some multivitamins also, and at the right time analyze where to stop using the drug rather than them going into the sarcopenia stage.
Great. We'll have an audience question, please.
Yes, it was a wonderful presentation by both speakers. I have one question regarding, is there any data about injectable semaglutide that it is causing ischemic optic neuropathy? Is there any data?
So the work at the moment is being looked into, and I would probably say await the data on this. So with the eyes, there are two things I wanted to mention. One is the optic neuropathy that you've talked about, the neuritis. It is definitely being looked into. So far, from our experience, we don't have any signals. We're using it quite widely. So we have the benefit of having a national screening service. But it's something we're keeping an eye on. But I always say, as with any new molecule and as any new drug comes along, it's our job to also keep an eye, which the company themselves are doing as well. Other thing I did want to mention about eyes was if you are treating somebody with type 2 diabetes who's got a really high HbA1c, then the potential is that the HbA1c will come down quite quick and fast and sharp. So just be aware that they don't have any existing proliferative retinopathy, etc., which might bleed. That is what we sort of tend to sort of keep an eye on. So those are the two things I would say.
So having said that, there are proven facts that when you aggressively lower the glycemia levels or aggressively try to lower the A1C levels, you tend to aggravate the proliferative retinopathy.
Okay.
So in any, either on the trials or when you use it in the practical thing, keep a check on your retina of the patients by a retina specialist properly. Subsequently, not in a, protocol ways like say 3 months or 6 months, keep an eye on their symptoms as well and then subject them for their
So
checkups.
before prescribing, either like specifically injectable semaglutide, do we need to have a
Yes,
fundus
I
examination?
have in my obesity clinic a set pro forma where what they have to do in 3 months, what they have to do in 6 months, what they have to do in 8 months, how frequently they have to go to the nutritionist or an exercise specialist is there on a paper. However, along with that, there are some deviations to that where we do some changes based on the requirement of the patient.
Or is there any, just last question, after stopping tirzepatide, or injectable semaglutide, like if patient has taken for 1 year, after stopping, is there any data how much weight, they put or they
Yeah,
maintain?
Surmount 4 trial is there. Surmount 4 trial is a trial where they have used the maximum tolerated doses of tirzepatide up to 32 to 36 weeks, and they have divided the patients into 2 arms. In one arm, they have withdrawn the drug and have monitored the weight, and in second arm, they have continued that for 72 weeks, and they have found that there was approximately, if I am not wrong, 9.6%, approximate 9.6% of weight gain, and those who have continued kept on losing, and it was some 21% with 10 milligram and 22.5 with 15 milligram.
And how much visceral fat in tirzepatide is losing apart from, overall, is there any data how much percentage of visceral fat, because it is more.
But before going on to that, I think it's a very important point to make, is that it depends as to how you see obesity. Because the conversation, for example, with hypertension or lipid raise isn't like, oh, your lipids are okay, let's stop the statin. And it's not an incredible surprise, and we obviously didn't go through it because of want of time. But it's very well established about the resetting of the body once you, with the hypothalamus and the way it works. So once you stop the drug, so this, I think this should be part of the advice that we give, is that if they want to stop the drug, due to whatever reason, could be cost, could be
not about stopping. If the drug is continue, if we continue the drug, how much percentage of visceral fat are is there any data?
No.
Loss
For
of visceral fat.
Visceral fat, there is no
Because
data.
in Asian people, central obesity are more common. That's why I'm asking.
I think you will find out more of the sub-analysis of the data coming through in the subsequent conferences on that one. And you make a very good point. Is it visceral fat? Is it subcutaneous fat? He will have maximum benefit with the visceral fat dropping. But I suspect more of that will come out very soon.
Okay. Thank you. It was
Thank
nice
you. We'll
and
have the last
wonderful
question
presentation.
by
Thank
the
you.
audience. Yes, sir.
Dr. Kar, your special comments on 2 specific issues. Some of these patients who are on an emergency surgery because of an accident or that have higher incidence of aspiration pneumonias. So do you have any specific recommendation for this subset of patient? Elective surgery can resort to these things.
Yeah, so in the UK, we, on the safety side of things, we suggest holding off a GLP-1 for 2 to 4
The emergency surgery.
Emergency surgery is always tricky. I think that's where the balance you have to have. So you go in with the risk known according to that they're on a GLP-1. It's always the balance factor that if you have to operate, right? It's a bit like somebody being on anticoagulants and you're having to operate. It's no different to that. So would we defer the surgery? No. But we are aware of the risks, and that's what anesthetists are aware
Do
of.
you suggest gastric aspiration if the patient is on an emergency surgery and going for anesthesia?
Not that it's given as a national protocol, no.
The second issue, some of these patients who is a prior gastropathy, when put on these drugs, when the drug is withdrawn, this continues, is not relieved rapidly. Do you have any specific drug for this problem?
Do you, from your experience? No. No, so are you talking about gastroparesis that they've got? No, not in particular. So I think if you've got a gastroparesis, not in particular, no particular advice on that front, I'm afraid, no.
My question is to Madam. Madam, in all 3 cases, between April and July, all the loss of weight was around 12 to 16 kgs.
Yeah.
Am I right?
Yes.
So it comes to an average about 4 kgs per month.
Yeah.
There are a lot of workers here. I want to know what should be the amount of reduction per month. 4 kg per month, don't you think it is much higher? It should be much less.
Yeah.
So I want
Ideal weight
opinion
loss.
from different people. 4 kg per month is too steep lost weight. Your comments, please.
Let me give a comment and then I'll let ma'am come in.
So the ideal weight loss is 1.5
Between April and July,
Yes,
the
yes.
loss of weight was 13 kilo.
Yes, yes.
So
I'll come
average
to
it comes to about 4 kilo per month.
Yes. So the weight loss ideal is 1.5 to 2 kgs per month is an ideal weight loss. However, if a patient has extreme comorbidities and you need to lose weight for controlling other comorbidities, it is advised to have initial few kgs of weight loss a little early and then maintain them on this. If you have seen the graph of both the patients, they have lost in 2.5 milligram. The first patient has lost with 2.5 milligram. And the reason was because in such patients who's on 50 units of insulin with 5 oral drugs combinations, the moment you give tirzepatide, the appetite goes down, and the first and foremost thing that happens is the need of insulin goes down. So such patients do not lose weight just by the effect of tirzepatide. They lose weight because you are reducing insulins, you are stopping sulfonylureas, along with that tirzepatide is be given. The rapid weight loss in such patients is because of combination of reducing insulin, stopping sulfonylureas, which in terms reducing the cravings and the peak and troughs by itself. So the graph was more in first 6 weeks, and that was the reason the 2.5 milligram was continued and wasn't increased earlier. Later on, after 3rd week, if you see, the weight was a little static and the patients are continuing with the same. The second patient which I had shown was having a severe comorbidity, sleep apnea. The first patient was also having sleep apnea, pulmonary embolism at a 27 years old girl who's breathless on diuretics and rivaroxaban. There is a need of rapid reduction. However, the other patients which I have shown, they are almost an average of 2 to 3 kgs of body weight.
So let me answer that question. I think it's very individualized. That is quite important. So if your starting weight is 150 kilograms or 160 kilograms, high BMI, then 4 kilograms per month is not a big loss. On the other hand, if you're starting at 80 kilograms, it could be a massive loss. And I think that's where us as clinicians become individual clinicians. So I think if you're worried that the massive drop in weight is too much, I think it's an analogy I always give is that that's where you decide how far you want to put the foot on the pedal of the gas, right, or the accelerator. So it depends. I think one of the very important thing about this drug is that is setting expectations as to what weight loss you're trying to get to, which is what ma'am said. So the weight loss on average, it's important to remember, if you've got type 2 diabetes in the background, the weight loss is less, about 12 to 14% in about 6 months. On the other hand, if you don't have type 2 diabetes, you can go down to a 20% weight loss, which is a huge weight loss, is the point I keep on saying. The pace at which you want to go is very much dictated by the personal circumstances. So if you are as a clinician, like, you know what, the starting weight loss is 80, and they're dropping weight too quickly, you can decide to hold fire a little bit, go a little bit slower. So I think it depends on the concern level you would have as a clinician on the individual patient to make that decision. But different patients do respond slightly differently as to how they react to the drug at the pace that we say. Because you'll find some patients, you keep waiting, and you have to ramp it up before you see any benefit. There is that as well. The final point is that 2/3 of the patients, according to the studies, benefited from it. It was not all the patients. So you will have varying responses as you go along. To be perfectly honest, as we have seen with insulin, SGLT2s, GLP-1s, and that's exactly where all the science of precision medicine comes in, which is being talked about by Andrew Hattersley and everybody. Is there something specific which makes people more responsive to GLP-1s compared to others? So I suspect there's more to come out on this field.
Thank you, sir. We'll have to take the questions offline, sir. We're waiting for the inauguration. Thank you to both the speakers, and we'll conclude here. Thank you.
Thank you.